Hi guys, I guess it didn't work out today, so let's do this CVPP lab online. Actually, this is going to be on YouTube because Virtual Classroom just completely crashed as well. So anyway, here we go. This is about the carotid pulses and blood pressure. So first let's talk about palpation and auscultation of the carotid artery. So as usual, the doctor is going to be on the right side of the patient, and the patient will be seated during this part of the exam. Get informed consent. Remember the anatomy. The carotid artery comes off the aortic arch. And, let's see. It comes off the brachiocephalic trunk on the other side, but on this side it's coming off the aortic arch. The common carotid artery splits into an internal carotid artery. That's right at the root of that, or the base of that. That's where the carotid sinus is, and this is the external carotid artery, which has all the branches. Splits into a superficial temporal artery, as we know, and a maxillary artery. Then the jugular vein, of course, the internal jugular vein is with the carotid arteries in a sheath, carotid sheath. This one is out. This is the one you can see that sometimes bugs out of the neck. Carotid sinus is very important. This is from Guyton. This is not anatomically drawn correct, because the carotid sinus should be right here. Right, it's at the root of the internal carotid artery, but nevertheless, there's chemoreceptors and there's pressure receptors too, and they travel. They're constantly tasting and sensing the pressure of the carotid artery, the internal carotid artery, and it sends its information down the nerve of Herring, which jumps on the glossopharyngeal nerve, and the action potentials actually hold the tiger cage. Let's say this is the tiger and this is the door of the tiger cage. They hold that tiger cage gate shut, let a little bit out, so you have a constant flow of sympathetic or a sympathetic tone, but not too much of it. If you poke on this, when we're teaching you to palpate, if you push really hard on that, it actually stimulates it, and it sends way more action potentials down the nerve of Herring, and it holds the tiger cage gate too tightly closed, and it decreases sympathetic outflow. And then nitric oxide rules, and you get a massive vasodilation, and down you go. You could pass out because the blood pressure drops really low. So that's why you have to be careful about poking that carotid sinus, which is located at the Adam's apple, at the laryngeal prominens level. So be careful with that. So the examination procedure, there are two safe places, and again, my references are Seidel and Bates. I don't use Jarvis. So there's two, and those are the two Chiropractic Board of Examiner reference books. So there's two safe places. You can put two fingers here, usually between the sternal and the clavicular head. You can put your fingers and feel it there. I can never feel mine there. The other place is you can slide these fingers past the laryngeal prominens. You don't want to put them here ever, because the patient could get, a last resort, because that's where the carotid sinus is. You slide these all the way up until this one bumps into the mandible, and that's where you can find it, just on the inside of the SCM. All right. Bates allows you to use the thumb. I'm not a big one of using the thumb, though. He says you can use either one, but it's better to do, and actually the fingers could be slid down a little bit because the clavicle looks like it's kind of right about there or so. So you could slide the fingers down. Definitely stay away from, it looks like the laryngeal prominence should be right about there. You can also take it up there as well, as demonstrated by Seidel. Okay. And who cares about this? Who cares about this carotid pulse anyway? Well, you can also get a pulse pressure there. You can feel the heart rate, the rhythm, and the amplitude. You may catch heart problems like a rhythm that's off beat, like palpitations, PACs, PVCs, PJCs. You can catch left ventricular failure or cardiomyopathy where the heart just isn't pumping very powerfully, where you won't feel a very strong pulse at all. You might catch a coarctation where there's a beaver dam just after the left subclavian takeoff from the vertebral artery, and you'll have very strong pulses in the carotid pulse, but you have very weak pulses in the femoral and popliteal pulse. You can catch a Watson's water hammer. Have I talked about that yet? Or also known as the Corrigan's pulse or the Corrigan's water hammer pulse. I will if I haven't, but it's a crazy, exaggerated carotid artery pulse. Like you don't have to feel it. You can see it with your own eyes. It bugs out so far, and it's not a good thing. It's caused by severe aortic regurgitation. And we'll get to that if I haven't talked about that in class. You're going to check for also hypervolemia or hypovolemic shock if that pulse drops enough. Turbulent blood flow can be palpated as well. So if there's an aneurysm in the carotid artery, when I say carotid artery, that means in the common carotid or the internal or the external. Carotid artery just is collectively all of those vessels. So turbulent blood flow, palpatory turbulent blood flow is a thrill. Auscultated turbulent blood flow is a what? It's a bruit. All right. So bruits. So according to Bates, and this is in the new, that's the 2016. The new Bates is just the same on this. I've already read the new Bates of 2016. You're going to use both the bell and the diaphragm, and this is kind of a new change. It used to be just the bell, but the research shows that the bruits can be high-pitched or low-pitched. So start with the bell, and you're just going to follow the carotid artery up. If you stay, the SCM would be about here. So if you stay just on the inside of the SCM, that's where you want to auscultate. All right. And let's see. Yep. So use the bell, and repeat it with the diaphragm. The patient should be holding their breath while you're palpating too, because the tracheal sounds will be really loud and you won't be able to hear things. All right, and there's hold your breath while you do that. Eliminates those tracheal sounds. Why are you auscultating? You're listening for bruits or turbulent blood flow. So if they have an atherosclerotic plaque in the artery, it may be, it's like putting your finger over the hose, and you can palpate that turbulent blood flow. That would be a thrill. You can auscultate for turbulent blood flow as well, and that would be a bruit. It's the same thing. They're both turbulent blood flow, just different words. So make sure you don't get those words mixed up. Okay, so atherosclerotic plaque, I mean, maybe there's a tumor, anything that's causing a beaver dam. And we said that water squirts past the beaver dam like crazy, even though the volume is decreased. So here, a carotid bruit, so what? Well, it's atherosclerotic plaquing. If it is, it's incredibly dangerous because a piece could break off of that plaquing and go downstream and get stuck in one of the cerebral arteries and cause a stroke. Patient could die from that. So very, very dangerous. Cervical manipulation is contraindicated if you do auscultate or palpate a bruit or thrill, respectively. You should not, absolutely not do carotid or chiropractic manipulation on their neck. They need to go for an ultrasound to confirm your findings, and they may have to have surgery to clean out that artery. Carotid massage is also contraindicated. In fact, based on a New England Journal of Medicine article, it's contraindicated, period, for you to do. You should not mess with people who have AFib, can sometimes do carotid massage and maybe get it to slow down, but you shouldn't do it because every now and then you go into ventricular fibrillation, the patient could die. All right, so that's pretty simple. Blood pressure, you know quite a bit about it, but let's some of the stuff you don't know. It's basically a measure of force that the blood imparts on the vessel walls as it's ejected during systole. Of course, it's like 120 millimeters of mercury when it comes squirting out, and then during diastole it drops down to maybe 80 millimeters of mercury. So systole is the high number, diastole is the low number. Pulse pressure is a difference between systole and diastole. And yep. Hypertension is, now I know they make you memorize all that stuff, all those numbers, but for boards, for Bates, Seidel, and Robbins and Rubens, the blood pressure numbers are the same as they've always been. They haven't changed them yet. So hypertension is anything greater than 140 systole, anything greater than 90 or greater. So if the patient has a blood pressure of 120 over 90, they have hypertension. If they have a blood pressure of 140 over 88, they have hypertension. And then there's a diastolic hypertension and systolic hypertension that we'll get to later on down the road. And hypertension is a risk for atherosclerosis development, and we'll get to that down the road, and peripheral artery disease. Malignant hypertension, dangerous, like you refer the patient to the emergency room, 180 over 120. That's a medical emergency. Hypotension is defined by the NIH as anything less than 90 over 60. Bates and Seidel don't mention what that number is, so I went to the National Institute of Health for that number. Confounders, this is really interesting. This is in Bates. So there's a white coat effect, which is kind of counterintuitive. This part you can understand, but the number is big. About 20% of people who come into your office, maybe a little more so with a medical doctor, but I mean, you might have the same effect on them because you're a primary healthcare provider. 20% of them get nervous and their sympathetics fire and their blood pressure goes up. So it's a mistake, in my opinion, for a doctor to immediately put someone on blood pressure meds because of this number. They need to send them home with a blood pressure monitor and make sure it's really true, because 20% of them really don't have hypertension. They're just nervous. Now here's a surprising number, the opposite side of the coin. Some people have very high hypertension, and the only time it goes low is when they come into the doctor's office. Maybe they have a very stressful home life. They have 5 kids running around, and it's just not a good, fun place to be. And they go to, and they're a worry wart. They're always worried. They're always on the internet. Oh, I got diabetes. Oh, I have this rare disease. You know the types. Worry warts. They come to the doctor's office. They feel safe. I mean, the doctor's right there. If something happens, it's quiet. And they might actually have low blood pressure. And 20% of them, 20% of people actually have this kind of reversed reverse white coat effect. So again, it's probably a good idea before you ever put anybody on blood pressure meds to give them a home unit or have them buy one. Those things are very accurate. Those ones you can buy. Most of them are. So that's another interesting little tidbit there. What may increase blood pressure? Well, stenosis. If you get a beaver dam in some of the big, like atherosclerosis, which is a member of arterial sclerosis, or PAD, or a tumor somewhere in one of the big pipes, the heart's got to pump harder to get through that. And so you might have, maybe your lower extremities may not have higher hypertension, but if you take an arm pressure, it might be high because the blood pressure is raised. Increased sympathetic tone. Always stressed out, smoking. Some people are just set like that. If you have too much outflow from the tiger cage, your blood pressure is going to go up. Renal artery stenosis. So if you have the renal artery tumored, or if you have atherosclerosis in it, and it's causing downstream ischemia, or not letting good blood flow down to the kidney, the R2A system will turn on and you have hypertension. Hyperaldosteronism, you guys are experts on that. Decreased arterial compliance, basically you lose that stretchiness of the arteries. That's stiffness, and that will increase if you don't, when systole shoots a big glob of blood up the ascending aorta, the ascending aorta stretches and the aortic arch stretches to kind of absorb the pressure of that blood flying out of the heart. If you have really stiff arteries, it's not going to absorb that pressure, and therefore your pressure will be higher throughout the system. All right, taking a blood pressure. Again, this is how I do it right from the boards, and I know it's a little bit different. But hey, I teach right from the boards. What can I say? Right from the board book, Seidel and Bates. Taking the arm pressure. So, yep, again, Seidel and Bates. First, you need to know the name of that thing. What do you say? You need a stethoscope. You can say that, but what about this thing? So, sphygmomanometer is the way you pronounce that. That's the cuff in the little dial thing. You should know the cuff sizes, like basic stuff. 40% you measure the circumference of the bicep, and 40% of that number will give you the width of the bladder. Remember, the whole cuff is not a bladder. The bladder is only the part that blows up. That's the bladder. So 80% of the circumference will give you the length of the bladder again, and this length, not the length of the whole cuff, it's the length of the bladder. Too loose versus too narrow. If the cuff is too narrow, then the blood pressure reading will be falsely high because there's not as much mass to compress the artery. If this is the artery, let's see, how can I draw this? You know my drawing ability is not good. And let's say this is the cuff, a little tiny thing. If you want to pinch this artery off, you have to put a lot more force to drive that little tiny cuff down. If you have a big cuff here, you don't need much force to push the artery down. So that's kind of the deal there. Now, if the cuff is ridiculously wide, then you'll get too low of a pressure. So too wide of a cuff gives you too low of a pressure because you don't need much force if there's a lot of surface area touching the artery here. This is the one that you usually don't know. What if the cuff is too loose? Well, if you ever for fun blew up a blood pressure cuff, normally when you blow up a blood pressure cuff, there's the bladder inside the cuff. It expands kind of normally or symmetrically. But if you keep blowing that cuff up and up and up, it starts to get a little point to it. So what it does, it decreases the surface area where it contacts the blood vessel. So it's like using a cuff that's too narrow if you put it on too loosely. That's why you have to put it on snugly. Supposedly the patient should avoid for 30 minutes smoking because that can artificially raise it. Caffeine, exercise. You want them kind of quiet. They should be sitting in a chair with 5 minutes to the exam, just relaxing. Always take, this is interesting. Now this is not in the board books. This is me inserting this. This is Weinberg's 2014. You should always take the blood pressure bilaterally. It's a really interesting study. They studied a big number of patients, thousands of patients, and they took blood pressure and they took the left arm pressure, took the right arm pressure, and wrote the numbers down. And then they followed them for 13 years. The ones who had either systole or diastole, a 10 millimeter difference between the right and left, they had a 38% higher chance of having a heart attack or stroke over the next 13 years. And they don't quite understand what the deal is or why that is. But it's significant. So if you have a patient, he's 120 over 80 in one arm, the right arm we'll say, and then in the other arm he's 130 over 80, you got to be careful. I mean, repeat it to make sure it's true. But he would fall into this Weinstein study. Or let's say he was 120 over 90. He would also fall in the Weinstein study. Okay, so here's the procedure. How do we do this? Now, this is where we differ from what they teach you. And I'm not going to talk for them. They're testing you, and I think they do things for speed, or I don't know. They've never explained to me why they do what they do. But this is the way. Even Jarvis, which is in the board book, all the books say to do it this way. Taking blood pressure is a two-step procedure. Step one is to find the cutoff pressure. Okay, that's basically systole. That's the one where you don't need a stethoscope. You're going to palpate the brachial artery and pump up the blood pressure cuff until you can't feel the pulse anymore. That's the cutoff pressure, and it's probably systole. Right? Then you're going to let the air out of the cuff. You're going to wait for 15 to 30 seconds to let the arm recirculate. And then you're going to go quickly and pump it up because you'll know your number. If the cutoff pressure is 120, okay, and you can back up and down. I'll show you how Seidel goes a step further and wants you to go up to 150 to look for an auscultatory gap, to kind of double check for an auscultatory gap. But if the cutoff number is 120, if you can feel at 115, you can feel the pulse, pulsing along, the brachial pulse. You go to 120, the pulse is gone. That's the cutoff pressure, 120. Then you're going to go 30 above that. Really, I mean, that's what the board books say. But really, I would want you to go 50 above that, because there are some auscultatory gaps that have been reported 40 to 50 millimeters in size. And we'll talk about auscultatory gap if you don't know. So the bottom line is you're going to know that you're going to pump up to 150. You're going to let the air out of the cuff, give them 15 seconds, put the stethoscope in your ears, get ready to go. No more taking pulses. You're just going to pump up now. You're going to tighten the cuff back up, put the stethoscope, put the diaphragm or the bell. They actually want you to use the bell, but I think the research allows for the diaphragm as well. But if you really want to do it like the board books, you should use the bell. But then you go. You just, boom, you're off. You pump up to 150 and let the air out 2 to 3 millimeters per second and take the pressure. Right? So two-step procedure. So let's go through it again. Find the cutoff pressure. So that is the pressure when you can no longer feel the brachial artery pulse. Right? It'll probably be the same number as systole, because that's what systole is. It's the point where you completely shut off the pressure. The blood pressure cuff is strong enough to completely pinch off the artery. Right? Unless there's an auscultatory gap, which we'll talk about. If the patient has an auscultatory gap and you keep going up, so you hear silence at 120, go up to 130 silence. Whoa, at 140 you hear pulsing again. And then at 145, 150 it stops again. That's an auscultatory gap. You can catch it going up and you can catch it going down, but you want to make sure you catch it. All right, so anyway, we're just finding the cutoff pressure. Put on the cuff. Make sure the artery marker is lined up over the brachial artery. The inferior border of the cuff should be about 1 inch or 2 fingers side by side. Index and the middle finger side by side is about 1 inch. So make sure it's not too low or not too high. And make sure it's tight around the arm. I don't think I've ever seen anybody put it on too loose or too tightly. So get it on as tight as you can. Guys with big biceps, it's hard. It's hard to get it on there. You have to put it a little diagonally to make it right. And sometimes you just can't get it perfect on them. All right, so finding that cutoff pressure. This slide's out of place, I think. Why? So you know how much pressure, so you know what the final pressure is. Here's just that slide was one out of place. So, I mean, the artery marker could have been a little better. It could have been right here. But there's 2 fingers. That's it. I can't really get 3 fingers under there, so it's a pretty tight squeeze. So make sure you do that. And now, how do you set up like this? I always remember right on right. So always try to do the right arm. But you're going to put, everything's right. You're going to put their wrist, you're going to pinch their wrist between your right arm and the right side of you. If you're a female, don't push their arm into your breast tissue. Pull it down a little bit. And then you're going to, your forearm will be supporting their forearm. And then you're going to give the ball and the thing that you pump up the blood pressure cuff with, give it to the right hand, because that's going to work the ball and the gauge. If you're right-handed, that's the way you should do it, because it's easier for your right hand. Then your left hand is free, has nothing to do at this point, because remember, this is finding the cutoff pressure. We don't have our stethoscope in. This Cutoff pressure is a palpatory event. So then come down on the brachial artery where we told you, where I want you to find it. It's in the crack of the elbow, just a little bit medial to the biceps tendon. It should be right in here somewhere, and you should be able to find it. If you can't find it, then you'll have to go down the wrist, but you should be able to find it. If you can't find it, lock their elbow out, because you're trapping the artery against the humerus, the head of the medial condyle of the humerus. It's very easy. Don't stick your fingers up under the cuff into their bicep, in my opinion. That's not the way the board books show to do it, and don't get me started. Okay, so that's it. And then once you get your fingers there, and you can, well, this cuff has a gauge right here. Yours might have the gauge on the pumping mechanism, so you can watch it right through this little hole here. And just pump it up, and you can go fast till you get to about 100. And there's just everything I said, the cubital crease. And if you go to the left side, I changed this because you can do the same setup. You can, if you grab their other arm, you can still pinch it between your right arm and your right side of your chest. You can use the same setup. Just pretend that's the other arm. You could go left on left if you wanted to, but I think it's too clunky. I think it's better just to do it the same way every time. And lock that elbow out. Right. And yeah, so palpate the artery. Once you've found it and it's pulsating, start pumping the cuff up. Now when you get to around 100 or 90, you know systole is going to be coming, so don't pump so hard. You want to go up in little tiny increments and keep pumping until you don't feel a pulse anymore. That's the cutoff pressure. And then Seidel, and this is relatively new, Seidel wants you to keep going just to make sure it doesn't come back to life. Right? So there should be no pulse. So if you pump up, let's say that happened at 120, if you pump up to 150, you should not feel a pulse. Person with auscultatory gap, you'll feel a pulse after a silent period. So that's the whole point of that. All right? So once you've pumped up, and you don't have to do that because Bates doesn't say to do that. Bates just says when you find the cutoff pressure, let's say it's 120, then your mission is accomplished. And your mission is to know how high to pump the cuff up. So you're going to pump up 30 above that to 150. Okay? All right, so let the air out of it. Now this is where our two techniques differ. You would just keep right on going with the school's technique. But if you're going to go strictly by the boards, you let the air out of the cuff and you let the patient hang out for 15 to 30 seconds. Ask them how the wife and kids are doing. While you're getting ready, now you're going to put your stethoscope, get it ready to go. So now we're going to take the blood pressure. So we already know the auscultatory, we know the cutoff pressure is 120. We know there's no auscultatory gap if you already went up to 150. But you know your target is 150. Put the earpieces in. Put the bell of the stethoscope on the brachial artery, Seidel and Bates. But research shows there's no difference, but if you want to be specific about this, use the bell. Quickly pump up. Now there's no poking, you're not taking any pulses, you're just taking the blood pressure. So you pump up to 150 and then let the pressure out. How fast you let the pressure out? 2 to 3 millimeters per second. What does that actually mean? If you say 1001, 1002, 1003, the needle should have went down to 140. Right? So every time you say 1001, 1002, 1003, you should have dropped about 10 millimeters. Sometimes you can see the needle gauge bouncing, and that's another kind of way to do it. There should be 3 to 4 needle bounces for every 10 millimeters that you go down. So that's the correct speed. And yeah, so you should know about the Korotkoff sounds. There's 5 Korotkoff sounds, right? Systole is the first Korotkoff sound you hear. Then there's going to be a change, a pitch change, and that'll be Korotkoff 2, and another pitch change, Korotkoff 3, another pitch change, Korotkoff 4, another pitch change, Korotkoff 5, and then there's no sound anymore. Right? So for you guys, Korotkoff 1 is systole. You need to know this. Korotkoff 1 is systole. Korotkoff 5 is diastole for you guys. This is also called second diastole. When I went to school back in the dark ages, back in the 80s, we used first diastole. We used Korotkoff 4 as diastole, which is actually more accurate, but it's the inter-observer reliability is not good. So one person, it's hard. There's a distinct muffling sound when you hit Korotkoff 4. But people, technicians and nurses assistants weren't very good at picking that up. So they changed it, I think in the 90s. They changed it to Korotkoff 5, which is second diastole. Okay, but you should definitely know the difference between first diastole and second diastole. Okay. Yeah, so I mean, here's a kind of a cartoon of our situation. So we've pumped up to 150, and now we're letting the pressure out. So silence, silence, silence. About 120, we're going to hear a first auscultatory sound. That'll be Korotkoff 1. Okay, and then that sound's going to make some different changes, and then the last sound you hear is the start of Korotkoff 5. So Korotkoff 5 is the silent period down here. Okay, and that's second diastole. I have another one to look at. This one's a little more in depth. So up here at 150, 160, wherever you're at, so you let the air out, you come down, down, down. You hear the first boom. You hear the first sound in your stethoscope. That's Korotkoff 1. Then you hear a kind of a lower pitch sound, and then it changes. And you can't detect these changes. I mean, you need an electronic stethoscope, I think. It gets a little louder. That's Korotkoff 2. And then it gets faint again. It's described as a knocking or banging sound. That's Korotkoff 3. But when you get this sudden muffling, which occurs right here, that's where Korotkoff 4 starts. And that's called first diastole. That's what we used. When I went to school, that was your diastolic number, but not today. And then you listen to that muffled, weird sound, and it's silent. Once silence starts, that's the start. I mean, Korotkoff 5 is really just one silent beat. That's Korotkoff 5. That is called second diastole. Are we good with that? Do we understand that? Just a note in Bates, patients maybe you will always hear a little bit of a sound when you get down to all the way down to 60, 50, 40. People with really bad aortic regurgitation, you might not get a diastole with them, right? It'll just keep going down and down. That's because the backwash of blood is so loud it's actually making an auscultatory sound. So people with aortic regurgitation may not have a diastole. Auscultatory gap again is a silent period. Let's go back through to this picture. So you're coming down, and an auscultatory gap, you have this silent period. Okay, and you hear a boom, 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 and all of a sudden it goes silent again. Maybe through Korotkoff 1 and Korotkoff 2. This is silent period. So, and then it comes back. Then you can hear another Korotkoff sound. So if you only pump your blood pressure cuff up to like right in here somewhere, and you listen, there's nothing there. You think you're up here, but you're really down here. So the first sound you hear is probably Korotkoff 3, but you think it's Korotkoff 1. See how that works? Really, Korotkoff 1 is way up here. So that's the danger of an auscultatory gap. Some studies show it's 30 to 40. Silent. It's seen in people with hypertension more than anything else. So it's important to catch that thing. Here's another example where let's see, it's like 170 to maybe 150 is a quiet period. If you only pump up to 160, 170, and you listen, there's nothing there because you didn't pump up high enough. Their systolic number is way up at 200, and you didn't find the cutoff pressure, so you didn't search for this auscultatory gap, so you can get faked out. And you could think their blood pressure is like, what, 150, when, oh, you got hypertension and go see your doctor, when really you should be sent into the emergency room because it's 200. So see how that works. Okay, it's seen in about 5% of the population. It's found in 21% of people with hypertension. And this today, they don't know what causes it. They know it's in people with hypertension. They think it might be related to arterial sclerosis or stiffening of the arteries. New England Journal of Medicine thought at one time, but they really don't know what causes it. Interestingly, these blood pressure cuffs you can buy, they use pulse pressure. They use a different way of calculating blood pressure, so you can't fool them with an auscultatory gap. So that's kind of nice. Fun facts. I've read this, this is not in the board books, but some authors have shown that if you raise the arm that you're going to test, so you're going to test the right arm, if you raise it, just put it straight over your head like this is a hold up, reach for the sky, and you hold it there for 30 seconds, and then you bring it down and take the blood pressure, it eliminates the auscultatory gap. So that might be a way to get around it. And there's just a review of the Korotkoff sounds. Somebody let me know if are they teaching you these Korotkoff sounds? I mean, because I don't know if they do or not, but you should know these. All right, see y'all later.